Good morning, everyone. My name is Doug Hoffman. I'm here today with Ryan Kruse to start our new season of our ultrasound case series. So we're now one full year into this. And the case series was begun by myself, Madeira, Call, and Ryan as a way to illustrate how to approach common sports medicine problems that we might see with ultrasound, with the emphasis on what is our protocol. So we like to emphasize protocol-based exams. What are the images in the protocol, the potential pathology in the protocol, and then to show the report that we do with the protocol and the exam performed. These are all half hour. And then they're posted on the AMSSM YouTube channel. So as a resource for anyone to go back and look at these. First, I want to welcome any new fellows that are here starting. And per last year, we'll have faculty present for the first 6 months, and then the fellows will present for the second 6 months. So it'll be about every 2 weeks, maybe a holiday thrown in there, and we'll skip on a Friday morning at 7:30 Midwestern time. But again, these will be posted on the YouTube channel. It's my pleasure to introduce Ryan. Ryan has been a partner in crime with me with this project. Ryan is a fast rising leader in sports ultrasound. He's originally from Chicago, the Midwest, did a residency at Mayo, his fellowship with Madeira Call in Iowa, where he stayed on as faculty. He's a high-end user, ultrasound, both diagnostically as well as interventionally. So we're pleased today to have Ryan kick us off on this new season on our ultrasound case series with athletic pubalgia.
All right, thanks, Doug. Let me end this presentation. All right, so hopefully everybody can see that. So good morning, and like Doug said, welcome to this kind of new series, or new season, I should say, of the sports ultrasound case series that we have. So I'm excited to start this off and get rolling with the next set of faculty presenters. What we're going to talk about today is a case of a rectus adductor aponeurosis injury, and I'll pause in a couple slides just to go over some definitions and some anatomy because I think a lot of terms are used and thrown about a bit to describe these injuries without really understanding what we're truly talking about. And so we'll go over definitions in a little bit here. So we'll just get rolling. Nothing relevant here. So as per our goals with this case series, and as Doug alluded to previously, I'm going to talk about a very specific case of mine from about, I think, 4 to 6 months ago, and walk everybody through my approach to this patient, my sonographic approach, and how I obtain images that satisfy a complete ultrasound examination. I'll talk about the normal and pathologic findings specific for this patient. As I've mentioned before, this is not at all meant to be an exhaustive, comprehensive list of all the pathology in the area, but I will talk about pertinent pathology for this particular patient. And then I'll briefly discuss my ultrasound report at the very end, how I put it together, what I think is relevant, so on and so forth. All right, so this is an 18-year-old kiddo, soccer player who I saw with rather insidious onset, progressively worsening, left kind of anteromedial groin and hip pain. He really points kind of deep into his groin, far medial. Notes that occasionally it'll radiate into his medial thigh, but now sometimes he might notice it, radiating superior and into his kind of lower abdomen, lower belly region. Initially, symptoms were really just with high level, powerful kicking. So, shooting a soccer ball or playing a long ball. But now he's noticing symptoms with running, even walking at times. And just recently, at the time that I had seen him, he was noticing that coughing, sneezing, bearing down, that sort of thing was reproducing his symptoms. Examination, just from an inspection standpoint, was grossly normal. Nothing really that would catch your eye there. He was exquisitely tender palpation over that proximal adductor longus tendon and over his pubic tubercle. I didn't palpate an inguinal hernia. He did have reproduction of symptoms, not only with active hip flexion, but also with an attempted sit-up, as well as Valsalva. As everybody has heard, most all of us say, there is a significant importance of obtaining radiographs to help with your diagnostic examination. And I tend to find that the one or two times that I scan somebody and I don't have X-rays, I can be thrown for a loop and find out after the fact that they've got some large bony mass or something that was throwing me off. So I always require radiographs as they are complementary to ultrasound here. And so for this kiddo, this is an AP of his pelvis. You can see over on the left side here, really unremarkable X-rays. Certainly no degenerative changes. I don't see any large cam bump or anything like that. So pretty unremarkable here. All right, so I took this off of the new AMSSM curriculum. And I would encourage everybody to take a look at that, as I think it's exceptionally helpful in terms of describing protocols that one should think about when evaluating these anatomic regions. But one point to note here is that this is not at all meant to be comprehensive nor prescriptive for clinical practice. It's more of a guideline, which then we all should tailor to our specific patient and the specific clinical question. And so for me, when I have an anteromedial hip patient, I tend to focus on these highlighted structures every single time. As part of my basic scan, this also again satisfies the requirement for a complete sonographic evaluation. And then these other structures that are not highlighted, I'll add these in as I find indicated. So just a couple points about anatomy and definitions here, as I think this is exceptionally important. A lot of folks, myself included, before I really had a great understanding of what the heck I was talking about, we throw around athletic pubalgia, sports hernia, core muscle injury, osteitis pubis, and I think for the most part, everybody is referencing an aponeurotic injury, but I think it's important to understand the anatomy and understand that these are not really all the exact same thing, and there are some nuances and involvement of different anatomic structures. And so I just wanted to briefly touch on this. So this top left picture, I really like this picture. I think it's really helpful for me anatomically to understand the complex interrelated anatomy in this region. And so, when we talk about athletic pubalgia or rectus adductor aponeurosis injury, it's this structure that we're talking about right here that courses over the pubic tubercle. So it's the confluence of the proximal adductor longus and the distal rectus abdominis tendon. Again, they kind of form together to form this aponeurosis right in this region. And this little kind of clock picture up here helps me orient myself with the far 3 o'clock, if we're talking about the right side here, the 3 o'clock position correlating to the pubic symphysis, and then the surrounding structures as described up in this kind of, like I said, top clock looking picture. Just a bit superior or cephalad and lateral, that's where you're going to find your superficial inguinal ring, your conjoint tendon, and so on and so forth. So I can certainly send this article to folks if you're interested. This is a great reference for the anatomy in this region. If you look over here on the right side of the screen at this right picture here, now we're looking at the anatomy of the inguinal canal. And just briefly speaking, the inguinal canal for the most part is formed by 4 walls. The anterior wall tends to be described as being comprised of the aponeurosis of the external oblique and the superficial inguinal ring. The superficial wall or the roof is really a combination of the aponeuroses from the internal and external obliques, as well as the transversalis fascia. The posterior wall is formed by the transversalis fascia and the deep inguinal ring, and then the inferior wall of the floor is primarily composed of the inguinal ligament. And so there are 2 types of inguinal hernias that we talk about, direct and indirect, which are really defined as a relationship to the inferior epigastric vessels. That's what I'll look for if I'm doing an inguinal hernia scan. Direct inguinal hernias occur medial to these vessels, where abdominal contents essentially herniate through a weak spot in the fascia of the posterior wall. Whereas an indirect hernia occurs when these abdominal contents course and protrude directly to the deep inguinal ring, which is lateral to these vessels. Now, I bring this up to contrast this to what's described as a sports hernia, for the most part, or posterior wall insufficiency. And so that essentially is weakness of the posterior wall, through which abdominal contents may bulge into the canal, but there's no actual wall defect. So the abdominal contents don't completely enter the canal. So it's more of a pseudo hernia, excuse me, and not a true hernia. So a sports hernia or a posterior wall insufficiency really isn't a true hernia. And then lastly, a femoral hernia. All of this again is in relatively close proximity here, but a femoral hernia occurs below the inguinal ligament, where contents will enter the femoral canal here. So again, just a couple points of anatomic definition here, which I think are important. And all this to say that when I describe these injuries, for the most part, I try and get away from these buzzwords, such as sports hernia and the title of my talk, athletic pubalgia, and all that, and really describe the structures that are involved in the pathology I'm seeing. All right, so we'll rock and roll with this patient here. So all of these slides are going to have my sonographic images on, for the most part, on the left here, with this bony pelvis top right, and then the transducer orientation to help show folks how we're doing the scan here. So in this patient, we're looking at his anterior hip joint. We've got nice rounded femoral head, as seen here, capsule coursing over the top here, and we're getting a peek at the anterior labrum over here. So all of this looks pretty stone cold normal. No effusion, no synovitis, none of that. As I slide a bit medial here, you've got a bit of a better picture of the anterior labrum here, which in this kiddo was normal. So my report, and what we'll do is go through my wording of the report for each structure as we go through it. So at this point, I would say the anterior hip joint's normal without effusion or synovitis. The capsule is normal. The anterior labrum is normal without large peripheral tear. For me, next I'll move to the iliopsoas. We're already in the general region here, so I'll just slide just a bit cephalateral, superior, and medial to get this nice image of the iliopsoas tendon. So I like to look at this as it sits right here on the acetabulum. We've got nice bony cortex of the acetabulum with the, like I said, tendon in short axis over top. I will then flip my transducer more into this anatomic sagittal plane to look at a long axis view of the iliopsoas tendon as it's coursing over the hip joint. I will follow this all the way down as it inserts some of the lesser. But for the most part, I tend to see a lot of pathology over the hip joint here. And then for almost always, but not always, I'll do a dynamic evaluation to look for dyskinetic snapping of this tendon. I didn't include the video, but in this patient, that was not present. Yep, here we go. Let's pull this back up. Sorry, guys, I told Doug that this might happen. I think one of my images has COVID, and so it keeps crashing my computer here. All right, apologize in advance if that happens again. I hope it doesn't. All right, so iliopsoas, tendons normal without tendinosis or tear, no bursal fluid, and again, no dyskinetic motion. So from here, I will slide my transducer a bit more cephalad and lateral and begin my evaluation of the rectus femoris. So here we've got rectus femoris at the AIIS and short axis here, normal looking tendon without tendinosis or tear. I'll then flip the transducer, and now I'm looking at the tendon in long axis here. So we got proximal left, distal to the right. Here's the AIIS. And you can see this nice hyperechoic fibrillar appearance of the direct head of the rectus femoris. And you can appreciate this hypoechoic shadow that's coursing downward in this image, but it actually tends to be medial. This is the indirect head of the rectus tendon. This is not the transducer position to evaluate this, but just know that this shadow is not pathology within the direct head. This is actually the indirect head, which I will show you in a second. After I evaluated the indirect head, if it was clinically relevant at that point, or at this point, is when I would move up to the ASIS to evaluate sartorius TFL, lateral cutaneous nerve, so on and so forth. But for this patient, it was not clinically relevant, so I did not do it. All right, so the indirect head can be challenging at first, figuring out the orientation of this tendon. And basic anatomy, the tendon essentially takes this rather oblique angle to course medially and insert on the superior acetabular ridge here. And so this is the transducer orientation for a long axis view, which is essentially of the indirect head, which is essentially a short axis view for the most part of the direct head. And you can see here on this image, this nice, again, linear fibrillar hyperechoic structure coursing onto the superior acetabular ridge here. And just quickly, this video I like to show folks as I'm sliding cephalad and caudal in a short axis plane of the direct head. You can see this hypoechoic shadow right here coursing downward on the screen. So that's the indirect head as I described previously. So in this patient, both the direct and indirect heads are normal without any tendinosis, and the proximal rectus femoris myotendinous junction was normal as well. After that, I come all the way down to the medial, the medial thigh, and this is where I start my adductor musculature scan. And you can see in this patient, so in a short axis, you have this nice stacking of all three adductor muscles. And again, transducer orientation, I start decently far down in the thigh here. But you see nice typical appearance of the longus brevis and magnus muscles here in short axis, and then flipping over into a long axis view. Again, you got that nice stacked appearance of longus brevis and then the very large magnus muscle deep to it. So at this point, my muscle evaluation is done. And I can say that the adductor longus brevis and magnus muscles are normal without fiber disruption or muscle edema. I then move. I just learned how to do these little slidey things with the transducer picture up here, so I'm very proud of this. So next, I'll move to the proximal adductor longus tendon, and this can be a bit more challenging than I think people realize to really obtain a good image of this. When I'm evaluating the adductor tendon, the proximal adductor tendon, this is what I like to have in view. So I've got proximal left, distal to the right. I've got this structure here is the adductor longus muscle. You can see this nice fibrillar linear appearance of the adductor longus tendon as it courses just superficial and in the region of this myotendinous junction here. This is actually a bit of a tendinopathic tendon, but regardless, these are the structures that I want to see when I'm evaluating this. Here's pubic tubercle, rectus adductor aponeurosis sits on top, and you've got rectus muscle over to the left. And I bring this up for a reason, which I'll show in a minute, but this is what you want to see when you're scanning the proximal adductor. And this is what you don't want to see. So in this patient, so again, here's that linear fibrillar pattern of the adductor longus tendon coursing over the top here. This is again the proximal adductor longus muscle belly, so myotendinous region here. And you can already see kind of in this region here, and maybe this is a better picture down here, but very hypoechoic heterogeneous. You completely lose that nice fibrillar architecture. And again, it becomes rather hypoechoic. So you see, rather significant tendinosis in the region of the proximal adductor. Additionally, we talked about the aponeurosis, and it's critical to identify an aponeurosis injury versus purely a proximal adductor tendon injury, because they're very different animals with very different treatments and very different prognoses. And so I will scrutinize this area and prove to myself that I don't see any sort of pathology in the aponeurosis, because again, that changes management. But unfortunately here in this athlete, again, all this adductor stuff going on here, and you can see this hypoechoic cleft that does propagate into the adductor and rectus aponeurosis. So this would be consistent with an aponeurotic tear here. And unfortunately, in this patient, so here's the rectus abdominis over here proximally. It did not extend into the rectus, but it stayed within the aponeurosis. And this patient, I didn't add the images, did have nice MRI correlative pictures. The last thing to mention in this view is here's the pubic tubercle. So significant cortical regularity, and everybody on here knows that that's one of the secondary signs of tendinosis with any tendon that we talk about. So all of these things, kind of clue you in, and there's some significant pathology in this region. So my report at this point says the adductor longus is significantly thickened, hypoechoic, and heterogeneous. There's partial thickness tearing in the deep 25%, which extends into the aponeurosis, but does not extend into the rectus muscle. I'll comment on the cortical regularity of the pubic tubercle. And as with anything, I'm a big proponent of sonopalpatory pain. And if I see pathology, I'll apply sonopalpation to see if it reproduces symptoms, and I'll always comment on that because I think that's incredibly important. Just quickly here, so I struggled with this early on, the transducer orientation to optimize your adductor longus. And I think a lot of us, when we're starting, we think that the adductor tendon is in this rather oblique appearance here, excuse me, oblique orientation here. But in fact, it's actually more in a almost near vertical anatomic sagittal plane here. And so this is that picture that I mentioned previously. Excuse the tendinopathy here, but you see this nice linear tendon over top with a bit of muscle deep to it. If you start seeing too much muscle, that means you're getting into the adductor brevis muscle, which is going to sit a bit more lateral here, and you don't see that nice tendon coursing superficially. So you're a bit oblique here. It's not an optimal picture to really scrutinize the tendon. So this is the view that you want to get here. So just a quick aside to make. All right, moving on. After I do my aponeurosis scan, I will come up into the rectus abdominis muscle. This is obviously a very thin, lean, fit athlete with minimal subcutaneous tissue. So this is a nice appearance of the rectus abdominis muscle, which in this patient is stone cold normal. Lastly, from the rectus, I will move on to the pubic symphysis. And so in this athlete, what really is highlighted here, so here's his left symptomatic side. And this it essentially looks like the Rocky Mountains, right? So there's all this cortical regularity at the left pubic tubercle, which is consistent with what I showed previously with the proximal adductor tendinosis, excuse me. Interestingly, and just a quick note here, so his right side doesn't look fantastic either. And in fact, we saw this kiddo, I think a couple weeks afterwards for right-sided pain. And he, in fact, had pretty significant right proximal adductor tendinosis, but fortunately did not have any evidence of aponeurosis injury on that side. So please don't use this right side as a correlative normal example. Is there significant cortical irregularity here? And then again, I'll comment on the cortical irregularities of the pubic symphysis with involvement of the left greater than right pubic tubercle. There's no Doppler within the symphysis. And then I did my best to only sonopalpate the pubic symphysis in trying to avoid either pubic tubercle here, excuse me. And there is no reproduction of pain with sonopalpation directly over the pubic symphysis, which again, I think is helpful, at least for myself when I'm reviewing my reports after the fact, as well as other physicians to that send me diagnostic scans to let them know that just because there's pathology, maybe the patient isn't all that symptomatic. And then lastly, just to mention my report, you know, there are multiple ways to skin a cat. I think a lot of us do these reports somewhat in the same organizational manner, but there are some nuances here. And so, you know, for me, I'll have the referring provider up front, our facility, why I'm scanning this patient, the study type. For the most part, for me, it should be a complete examination. There are some examples where I'll do a limited evaluation, but it's usually complete. I'll comment on my ultrasound unit, which transducer I used, where I'm at with my transducer, the laterality, and then my findings. I'm not going to read these. I've already mentioned them during the talk. But for the most part, I try and just be descriptive in the findings section. So I say what I see. If there's tendinosis, you know, I'll say there's some hypoechoic heterogeneity. For the most part, I won't say there is tendinosis, but sometimes I do. And as I just said that, I clearly said that right here with the iliopsoas. But for the most part, I try and be descriptive rather than make clinical decisions. And then down at the bottom here is where I'll interpret my findings to give a clinical interpretation down here. So with that being said, that is the end of what I have. So I am open to any questions anybody has. Otherwise, I'd love to, Doug, hear what your thoughts are, and if you could share or want to share your protocol, I think that would be exceptionally helpful.
Great, Ryan. So unfortunately, or fortunately, because I follow you next couple of weeks, but you set the bar high here for the way the presentation is done. There was one question, and the question was recommendations on position and clothing for the patient for this scan, especially for the adductor tendon part of the scan.
That is such a great question. That's a really great question. And so so I've changed what I've done a bit recently, and by recently I mean the past probably 2 years. But I used to always frog leg my patient, and I've gotten away from that for a few reasons. You know, now I just have them, you know, supine. Maybe they tend to actually rotate their hip a little bit, but I do not frog leg them. Reason number one is if somebody has pathology in this region, you know, what I found is that if I frog leg them, you're putting the tendon, the adductor tendon and aponeurosis on stretch, and they probably don't like that nor appreciate being in that position. And I also just didn't find that it really helped me at all. So now I have them completely supine. And I think, you know, my scans go much more smoothly and the patient is more comfortable. Regarding patient clothing, that's a completely different beast to tackle. I used to be very conservative and you know, keep them as covered as possible, which I still think is important. But you know, everybody knows this tendon, this aponeurosis, is pretty darn high. So I'm a bit more apt to expose them. Obviously keeping, you know, certain regions covered. There are some, for lack of a better term, like adult diaper type things or slings that you can use to essentially pull certain sensitive structures away from this area. But for me, I'm essentially, you know, just using a sheet, covering the bare minimum and exposing what I need to so I can get an accurate exam.
Yeah, and that's what we do too. So for all hip exams, regardless, even my lateral hip, because I do an anterior hip with it, we have the patient undress completely, and then we have a sheet over them, and then just move the sheet or even scan under the sheet, especially, you know, for a teenager, because yeah, we really need to be able to get all those structures that can be very hard if they still have some clothing on. About the protocol. So yeah, I mean, I think that's pretty much my protocol. Just a couple quick comments. And one is that, as Ryan alluded to, that adductor longus tendon, as it inserts onto the pubic tubercle, often does not look normal. And in fact, where I am in northern Minnesota, and we have a lot of hockey players, it never looks normal, whether there's pain there or not. And of course, if you have a runner, it is unlikely to look normal. So the one thing that I add is if I see pathology or abnormalities of the adductor longus tendon or that conjoined tendon between the adductor longus and the rectus abdominis, I always get comparison images. And then secondly, I say exactly what Ryan does, and I talk about sonopalpatory pain. And I make sure I can even compare sonopalpatory pain because the symphysis pubis and pubic tubercle are kind of a little bit sore in a normal state in some people. So I'll go ahead and compare the two sides. And sometimes its pathology in this region can be quite subtle because of the fact that it's almost never normal in some of these athletes, or looks normal in some of these athletes. The only other comment I would make is I probably would have gone and quickly have had the patient Valsalva and make sure I don't see, and if it was a female, femoral and an inguinal. It'd be very unusual to see a femoral in a young male, but I have seen it. But I would have checked for an inguinal hernia, particularly because some of those fibers of the adductor longus and rectus abdominis conjoined tendon form the medial wall of the superficial ring. And I've seen insufficiency of the superficial ring itself. So I would have probably just checked for a hernia, and then I would have slide my transducer a little bit cephalad in that transverse plane and get on the rectus abdominis and the inguinal ring, or in the inguinal canal or the spermatic cord, have them Valsalva and see if there's a diastasis, which would again signal transversalis insufficiency. And I just want to reiterate that, Ryan started with the hip joint. And even in our MSK ultrasound department, where I am, we do all the hernia exams for the organization. We always start with the anterior hip joint, and probably 1 out of 20 patients, their groin pain is hip joint disease and not a hernia. And so over time, I've felt that I've kept that in my protocol, even if I'm not, seeing an athlete specifically. Just let me check if there's any more questions. I don't think so. Any other comments, Ryan?
I'd be curious, Doug, just to hear your thoughts. I mentioned previously that I think that athletic pubalgia, core muscle injury, sports hernia, osteitis pubis, so on and so forth are thrown around without, really great understanding of what we're talking about. I'm just curious, when you do your scans for this region, are you using those words when you're in your report? Or are you more so just describing what you're seeing, or what's your experience been?
Yeah, so I have to give Tony Joseph a little shout out here and credit, because he's done a lot of work with ultrasound with this, and I have gotten away from using those words. But the reality is people are referred saying ? Sports hernia, and so when I in my report, for example, I will describe saying there is no diastasis between the rectus abdominis and spermatic cord with Valsalva, and therefore the transversalis fascia, I won't say this, is intact. And so I will say there is no diastasis specifically to suggest insufficiency of the transversalis fascia. And in my report, if that's the reason why they were referred, I will say, there's no evidence of transversalis insufficiency, and I'll put in parentheses, sports hernia, just to make sure that they understand that I checked for that, because the referring provider might not understand, exactly what a sports hernia is. So for me, with this patient who presents with groin pain, this would, for me, have been our hernia protocol, which exactly the anterior hip is exactly what you do. And in our hernia protocol, we can expand or contract some of the images. So in this case, if this was a 75-year-old person of a question of a hernia, I'm not going to go through the whole adductor longus and rectus abdominis and pubic symphysis. I'm going to look for a hernia as they ask, unless it's negative and there's a reason to look for it. But in this particular person, it would have been my hernia protocol plus the expanded protocol of looking at the structures that you looked at. So that's just the way we approach it. So this wouldn't have been our anterior hip protocol. This would have been our hernia protocol that is expanded. But that's, again, this is why we do this. We talk about some of the differences and how we do things. And again, I get away from language of pubalgia, sports hernia as such on a regular basis.
Sure. Thanks, Doug.
All right. So that brings us to conclusion on a Friday morning. Again, Ryan, we set the bar and example moving forward here. We do have one in 2 weeks, and I'll be presenting an inversion lateral ankle injury. And again, these are posted on the AMSSM YouTube site. And have a good Friday and a good weekend.
Thanks, Doug. Happy Friday, everybody.